What information? Do I need to know?
No, I just realized I could be doing a little bit better than what I'm doing.
Alright.
Your dedicated was going as bad as mine. It's fine.
No, I think you got me.
Don't put them right against each other. The new one probably does.
I just thought about it.
Oh, okay. So the next thing we're going to talk about is nephrotic syndrome. And this does have exacerbations and remissions. Y'all are recording me again. That's just creepy. the sound is good. I just better not see it on Facebook anywhere.
Oh, no ma'am.
Or anywhere. Okay, so nephrotic syndrome, it does have exacerbations and remissions. So it's got to have some type of genetic component to it. But what we want to think about with this one, and a lot of times glomerulonephritis can cause this, can lead to this. But what happens, our glomerulus right here, you know, where we're filtering everything, we don't filter big molecules like proteins. Albumin is the smallest of those. And the holes or the filtration system gets big. And I want you to think about Swiss cheese. You know how we have big holes, little holes in Swiss cheese? And that's what happens to your glomerulus. So that protein is able to filter through. But then it can't get back across and get back into the blood, so it gets peed out. Our normal urine protein is about 0.15. Patients with nephrotic syndrome, 3.5. That's like a huge amount of protein that we're losing. All that albumin. Why is that important? What does albumin do in our vascular system? Can anybody tell me? Think back to patho, your favorite course.
It's something like
Is it a low clotting factor?
Okay, something's not what?
Doesn't it help clotting?
Nope, not clotting.
I would say something like a loop factor.
No, that's loop diuretics in that little downy thing in the nephron. Albumin. No, I think of more nutrition-wise. Oh, yeah, it's great. Nutrition, we need it, yes. It's our building block. We need albumin. But albumin regulates the osmolarity, the pressure, the oncotic pressure in our vessels. What's that mean, Dr. Ware? That means, think about albumin, these little fluffy sponges floating in your blood. And what they do is regulate so that the pressure is such that I got enough fluid in my vessel and I got enough fluid outside of it. Everything's equilibrium, everything's good. And those albumins act like little sponges, keeping that fluid where it's supposed to be. Now, if I pee all that fluid, those sponges out, when I get all my fluid running through my vascular system, it's going to go crazy because, whoa, nobody's holding me in here. Boom, out into the extravascular it goes. And what's that going to make the patient look like? A balloon, yes. They're going to have edema. That's that squishy +4 edema, +3 edema, because it's all in this extravascular spaces, intracellular. It has messed up my oncotic pressure, so my fluids are now all going wherever they want to, and they're not staying in my vessels. So I've lost a lot, and you're going to get protein dipstick in the urine, and the vessels get very leaky, and out goes all that fluid. So we see those people have a lot of edema. So it's a severe loss of that protein, albumin being the one. Now, these patients end up having high cholesterol, high triglycerides, because their liver function is altered. Their urine looks foamy because they have more fat in their urine. They hold on to all that fluid, and they also have very poor appetites. Their blood pressures go up a little bit, but not too bad. Albumin in their blood is low. They have hyperlipidemia, and we're going to give statins for that because diet doesn't help that. But the edema, periorbital, the dependent edema, if they're sitting in a chair, their feet will swell up. Waxy pallor to the skin. So our goal is to control the symptoms that they're having. Relieve them, prevent complications from the kidneys. And blood pressure control is probably one of the biggest worries. We want it to be below 130/80. There is immune system involvement, so we use immunosuppressants. You may actually see your patient be given albumin, so we can replace some of that that's lost. But the problem is, we put albumin in the vascular system, and then our pressure changes again, and whoo, all that fluid comes back in, and we can overload their hearts, right? So we give them the albumin followed by Lasix to flush out the extra fluid that just came in from outside the vascular. Angiotensin ACE inhibitors for their blood pressure. It also decreases loss of heparin can prevent clots, which would so we increase our perfusion to the kidneys. It also helps in decreasing loss of protein in the urine. What else we got? Diet changes. So we got to look at that GFR. We need protein here. So as long as our kidneys are doing pretty good, we need to get that protein in. So usually a gram per kilogram per day, moderate amount of protein goes, but we do decrease that sodium to help keep the blood pressure down. Already said statins because diet doesn't really help here. So these vital signs are going to help us. I mean, these interventions, or some of them are assessments, that's going to help us keep track of how we're doing with this. Our vital signs, our I and O. They are on bed rest as long as they're edematous. Daily weights, the diet. Potassium, if their kidneys are failing, their potassiums can go up. But if we're giving them some Lasix, it may keep the potassium okay. So you need to monitor that. And then the other medications. So always think about not just I'm giving this this potassium because I just gave Lasix and I don't want the potassium to go down. But we got to know what their potassium is doing. They might not need it with this one because their kidneys could be holding on to enough that their potassium level stays fine. So I'm always looking outcome. Outcome. Why am I giving these drugs? Is it doing what I want it to do? And complications. All right, this is nephrosclerosis, thickening of the narrowing, which is going to do what for our kidneys? Increase pressures, decrease perfusion, activating renin-angiotensin. So these patients have hypertension issues. So the big thing for patients with nephrosclerosis is to manage their blood pressures and preserve renal function. ACE inhibitors and diuretics if they have volume overload. their blood pressures are a little more difficult to control. May not get their diastolic under 100, but we want to try to keep them down below that. They have to stick to their meds. Those blood pressure meds are very important. If they miss a couple, then their pressures can shoot really high. What's a side effect of ACE inhibitors? A common? Oh, y'all given ACE inhibitors. What did you tell your instructor was something you were going to watch for?
Dizziness. Heart rate? Cough.
Cough, dry cough, nothing coming out. Can be a sign of pulmonary hypertension. Not a good outcome. And it's not uncommon. It can happen pretty quickly or long term. I've been on ACE inhibitors for 5 years when I started having that chronic cough. I didn't really think a lot about it because I've been on them for so long. But sure enough, we stopped it and cough went away. I have a friend who I went to go to the beach with, and she stays in her room, I stayed in mine. We went one weekend, and good Lord, she kept me up all night coughing and hacking. I got up the next morning, I'm like, what in the world are you doing? Are you taking antihistamines? What are you doing? She's like, I'm not congested. I'm not coughing anything up. I just got this dry, hacky cough. She said, how long you had it? About 3 weeks. Geez. And then I thought, wait a minute. Did you go to the doctor last month? She said, yeah. I was fine. And I said, did he change your blood pressure medicine? Yeah. Put her on an ACE inhibitor. So, sent her back to the doctor. Her cough cleared right up. I said, I'll go back to the bench with you when you get that done. It was bad. All right, here's our polycystic disease again. Outside of a kidney, and here it is on the inside. All these cysts in there. So they're in and out. And as we said, it's going to cause abdominal pain, flank pain. I mean, they're going to have a lot of pain from that pushing. Not only from the pushing, but also these things get infected and they can burst. And that causes pain. Hypertension, absolutely. Nocturia, they get up at night because this is really not doing its job. Okay? So he's not concentrating. Increased abdominal girth, bigger. Got to have space in there. It's pushing against your GI, so constipation is another big problem for them. Hypertension, constipation, those are two of the biggest ones. They also tend to have more kidney stones, headaches from a little uremia that they develop, or those kidneys fail. Aspiration on the cyst to try to make them smaller. That girl, as I said, the picture I showed you with the 2 huge kidneys, she was only in her 20s. Some people will start to develop symptoms not until their teens, but she had been having issues since she was, I think, 6 or 7 years old. So they grew and grew and got worse and worse till she had to have them out. They will eventually have to go on dialysis because those kidneys don't work very well, and transplant is what they'll end up with.
Since it's an autoimmune disorder, if they get a kidney transplant, would it happen again?
That's a great question, and I'm not sure. Possibly, but if they don't transplant them, they'll die. So, I need to do a little research on that. So ultrasound, MRI, urinalysis, those kind of things can give us some more information on what's going on with the patient. And then we can cure it, but we're going to treat it. We're going to treat symptoms. fluid therapy to keep the blood pressures down, to help with keeping that sodium retention from happening. We're going to monitor their DU and creatinine and their GFR. And pain management is going to come not only with, not in the usual, we want to use antibiotics. This pain a lot of times comes from infections in the cysts. We can use dry heat over the kidney. They need to learn how to do self-blood pressure checks, how to know when that weight gets enough that they need to call, that they might be getting fluid overloaded. They need to know all about the medications and the side effects of them like anybody else. Dietary-wise, we're going to decrease their sodium. We're going to increase fiber for constipation. We need those kidneys, that GFR working pretty well though. So we're going to have to monitor the GFR, and as the GFR goes down, we'll have to back off of proteins. Constipation, of course, exercise, but they have more pain when they're up and moving, less pain when they're laying down. So that's a little problematic. The other thing is increasing fluids and fiber. Well, our kidneys aren't working. As the kidneys start to fail, we have to be really careful with increasing those fluids because we can overload them. But the major problems are the constipation and the hypertension, and management of patients with polycystic kidney disease. All right, nephrosis and hydroureter, we've really talked about this already. We know that stones are one big problem that can lead to this, and it's because of the increase in pressures, and these can lead to renal failure. So we really have to watch our patients and monitor them. We want to know if recurrent childhood UTIs may be relevant if they have scarring of their kidneys. And they could get into AKI quicker if they've already got some damage. We want to watch that flank. We want to watch their urine output. That's a biggie. And keep an eye on their BU and creatinine. We're going to CT or ultrasound to find that stone and see if we have any hydronephrosis or ureter, any swelling in either area. The renal impairment can happen quickly, remember? And you may start to see even increases in potassium and the electrolytes, and even metabolic acidosis developing as those kidneys fail. They can fail hard and fast. So, they're retaining all that urine. What's the problem with that?
If it's acidic, it can lead to like UTIs and stuff like that.
Yeah, it can lead to infections, and it's putting a lot of pressure on those kidneys. The kidneys are working, and they've got an increased risk for infection and the acute kidney injury. So treat what's causing the problem. Get the stone out of there. Sometimes they have to have a nephrostomy tube placement. And we talked a little bit about the nephrostomy tube, that it can be a sign that it's blocked or clogged, maybe that back pain and referral pain. We have to have an order to irrigate it. Anytime patients are going for any type of GU invasive, we need to do clotting studies, okay, because that is a very vascular area. Always be checking that urine output, and for patients that you think may have problems with this, it should be hourly. And especially if you've got a nephrostomy tube in, you want to be checking that urine output every hour to be sure we're still good. All right, so the nurse is reviewing the client's lab days before nephrostomy. Without treating it. White blood cells in the urine. Would you expect that?
Yeah.
Yeah. INR of 2.1. Anybody know if that's low or high?
Well, if treatment, that's when we ramped up 2 to 3, but if not, it's low.
Yeah. This shows bleeding. Bleeding time is short. So we probably need to give some platelets here and get that patient's clotting up better. Hematocrit, 44%. It's nice. Creatinine 0.8. That's normal. So it's the bleeding, the clotting factors. Okay, renal vascular disease. Think of this as you would a heart. The coronary arteries, they get blocked. They get stenotic. They get a little stricture in them, whatever. That is the same that happens to our artery, our renal artery. That's what's here. This particular thing, though, it's just like a heart attack. You may be going along just fine. My nephew had a bad car accident when he was about 19. In the ICU, was doing okay with all the injuries and stuff, but they couldn't get his blood pressure down. They started doing renal and checking on that and discovered that he had a stricture that had almost closed off his renal artery. So they went in, did a roto-rooter, cleaned it out, just like, you know, a coronary, and he did great for about 20 years. When he turned 40, he's monitoring his blood pressure. He's doing good with it. All of a sudden, blood pressure went up and he couldn't get it back down. Went in again. It had started closing off again. So this time they put a stent in. Okay. Which was odd with him because you usually think about right here is tied off, is smaller, has a little stricture in it. But you just go in there and open it up. Balloon angioplasty thing. So you look at it and open it up. You can even do a bypass if needed. All right, and then we're going to talk about a little diabetic nephropathy. Most people don't understand outside of nurses why, if I let my sugar go up and down, what does that matter on my kidneys? And it matters a lot, doesn't it? It's getting more and more important. Now, I've got you a little video.
The development of diabetic nephropathy
Oh,
involves
nursing.
hypertension and hyperglycemia-induced changes in multiple pathways that contribute to morphological changes in the kidneys. The glomerulus is a globular-shaped structure composed of capillaries that are actively involved in the filtration of fluid from the blood to form urine. With diabetic nephropathy, early glomerular hemodynamic changes include hyperfiltration and hyperperfusion, which result in microalbuminuria. Increased afferent arteriole dilation due to a dysfunction in the vasoconstrictive autoregulatory response contributes to increased intraglomerular pressure, which is associated with greater mesangial cell matrix production. Expansion of the mesangial area, an early morphological change with diabetic nephropathy, is caused by greater extracellular matrix deposition and mesangial cell hypertrophy. This expansion is associated with a decreased glomerular filtration rate and a reduction in the surface area for filtration, which marks the beginning of renal failure. As this process continues, the glomerular basement membrane thickens, and this may eventually lead to glomerulosclerosis. All of these changes in glomerular hemodynamics cause stress and strain on the kidneys, which, if left untreated, may result in renal failure.
All right, y'all got that? Lot of big words. Basically, that hyperperfusion causes a lot of fluid to leak all around that nephron and in the glomerulus. And then when he was talking about the basement membrane and stuff getting bigger, well, that's shrinking the tubules in the glomerulus so that filtration slows down and it's not able to pass through there. So it also increases pressure. So because of all those different things, the glomerulus can actually die. And then you got no filtration for those. It damages and destroys eventually that glomerulus. So some patients that are still producing a little insulin may say, hey, but I don't have to take as much insulin. My glucoses were better. Well, unfortunately, that sounds like a good thing, but that's a bad thing. Because what that means is, like you and I, we filter some insulin out. And what that means is that their glomerulus, they've got enough nephrons killed off that they're no longer able to do that. So that insulin, that little bit of insulin they make is still in their body and working a little bit. So that's not really good when they tell you that, although it sounds great. It's not. So the first things you're going to start seeing, as I said, they spill protein. That all becomes very leaky, and that protein gets in the filtrate, and we start seeing protein albuminuria in the urine. And that in itself can be toxic, and all these toxins start to be toxic to the actual glomerular cells themselves. And some things that can cause this, if we've already got diabetes and we're putting a lot of pressure on our kidneys, then we don't need anything else that can damage them, like being dehydrated or being given nephrotoxic drugs, an antibiotic that's kind of hard on the kidneys. They don't do as well with that. I know in our hospital, all antibiotics that get ordered, go through the pharmacy. The pharmacist asks if they don't already have one for calculated GFR and looks at their BUN and creatinine and will adjust the dosage depending on how well that patient's kidneys are working. Because antibiotics can really rip up the kidneys. They're wonderful, but diabetes is actually the #1 cause of end-stage renal disease. Patients ending up on dialysis and ending up needing a transplant. And the severity of it is related to the degree of hyperglycemia, how many times that patient gets hyperglycemic and comes back down, goes back up, comes back down, goes back up. It increases the damage. So that's why it's so important for them to understand that, and to understand that just because your glucose was 100 this morning, that A1C is 9. That tells me that you have not been steady, and that's a problem. Okay? So treatment for this is blood sugar control. Manage your blood pressure because that's a comorbid. And this diabetic nephropathy and renal failure is the #1 cause of death in patients with diabetes. So it's real important. All right, renal cell carcinoma. carcinoma is the most common. Luckily, we got 2 kidneys, and this usually only occurs in one of them. So we got another one that can help. But same thing, remember we stage in that bladder, you stage these kidneys. Metastasis goes usually to that adrenal gland that's sitting right on top of it. Liver, lungs, long bones, the other kidney, but usually they have found it by then. Now that pan-neoplastic, it can spread everywhere. And one thing that can occur is either anemia or erythrocytosis. Because remember, the kidneys are involved in that production of the erythropoietin. And these tumors will either increase that or decrease that. Okay? Hypercalcemia, they produce a lot of calcium because they stimulate the parathyroid and release of the parathyroid hormone, which increases production of calcium. Their liver is affected, and they can get that fatty liver, frothy urine. The hormonal effects, as I said, the parathyroid and the erythropoietin, increased sedimentation rates. Remember that. Chemotherapy and radiation are generally used to shrink tumors. Biological response modifiers like the interleukins help some, but most of these patients now. Of course, if we've got metastasis, we still need to do this, but then we'll have to treat the bone cancer and the lung cancer and everywhere else. The chemo will help to shrink the tumor. Function and start getting it, their level of consciousness will change, their urine output will drop. So you need to be assessing and looking for those complications. Pre-op, that blood clotting factors is real important. These tumors are very vascular, and your kidneys are pretty vascular, right? And post-operatively, we're sitting in a semi-Fowler's position. So remember, we talked about bleeding and how they can bleed because their incision is over that flank usually, behind, and you won't see it. Or they can bleed into their abdomens. So you look for abdominal distension also. Measure their abdominal girth. Gland will pick that up. But sometimes the adrenal gland doesn't quite do the job, and we'll have something called adrenal insufficiency. And what you'll see when that starts to occur is a large output, and then all of a sudden nothing. And they get hypotensive. So that's a complication you need to monitor for. If the other adrenal gland doesn't pick up enough, then we have to supplement corticosteroids until it does. The other kidney should pick up with output and be able to cleanse just fine. But sometimes after surgery, it needs a little push. We don't have good output. You might see them give a bolus of fluids just to tell that kidney, okay, take care of this fluid, let's get going. And they can even follow with a little mild diuretic to keep it, to get it going good. So, what do I look for to tell me whether I've got post-op bleeding or not? What am I going to look at in their vital signs, Elena?
Looking at your heart rate,
Heart rate and what?
blood pressure.
Blood pressure, because they're going to get hypotensive and tachycardic. They're going to have a change in their level of consciousness. They might get confusion because they're not getting enough oxygen up here. Okay? Decrease urine output, abdominal distension. You can bleed inside. And then the last thing in here is kidney trauma. Blunt injuries, car wrecks, urological procedures. There are 5 different grades. We're not going to go into those, but you can cause trauma to that kidney, hopefully just one, because we do have another one. And since we do, we can assess for how bad is the damage. Is our BU and creatinine going up, or is the other kidney, do all your assessments for how well is our functioning going with fluid electrolytes, with BU and creatinine, H&H, ultrasound. Those can look at the problems. And then sometimes we just have to wait for that kidney to heal. If it's a bruise, a contusion, they may let just support that kidney, manage their blood pressure so that they're getting good perfusion. They may need vitamin K and platelets if they're complete nephrectomy. If the damage is these are the chapters that your ATI, pediatric, because kids are not just smaller people. Remember we talked about acute glomerular nephritis, that we have to be careful with kids that get strep throat, because they can end up with this, and that can lead them to have some damage that will lead to hypertension later on in life as they get to be an adult. Nephrotic syndrome, renal failure, chronic renal failure, those are the chapters that you'll see specific for kids in your ATI. Okay? You need to stand up while I change some things around. We are going to start looking at acute renal failure now. Okay? That is not a day, any of the day things, like day 1, day 2, day 3. It was its own little entity PowerPoint on acute and chronic renal failure. And we're going to talk about chronic. Acute. Yeah. So y'all get yours, I'll get mine. First page looks like, or maybe it has the concepts on it. All right, so this chapter looks at both acute and chronic. They're very different. but they're also a lot alike. Okay, so let's talk about chronic right now, and just for a second about cost to the healthcare system, how much there is, how many people are on dialysis. You know, our society likes our food, depending on the region of the country you're in. Diabetes is going up, pre-diabetes is going up, hypertension is a problem, obesity is a problem, and those are all things that can lead to that chronic glomerular nephritis. And diabetes and hypertension are the three big things that lead to end-stage renal disease. 15% of Americans, last time they did a survey or whatever they do, 15% of them have end-stage renal disease. That's a lot of people. They estimated that to be around 37 million people. The cost of our healthcare system, with just that, and well, let me back up just a minute. 95% of the people, or 90% of those people, or those 15%, don't even know they have kidney damage. They're the ones that are walking around with high blood pressures, or with pre-diabetes, or with chronic glomerular nephritis, and they don't realize that their kidneys are being damaged every day. So medical costs $70 billion. Y'all don't have to remember these, but hypertension, $131 billion. This is what Medicare, Medicaid, healthcare pays to manage these problems. Obesity, $190 billion. All of that added together that affects our kidneys is $1.25 trillion. If we could just be a healthy nation. But that's really hard. All of these comorbids that we look at, the diabetes, the hypertension, it's hard for people to manage those things. Hypertension, you don't even know you have it. Diabetes, things go up and down, lots of good food out there, and that's hard to manage. So keeping these kidneys in good working condition can be difficult, and it takes up a lot of our healthcare dollar. This is one of the biggest things that takes up our healthcare dollar. And you saw that cardiovascular is involved in that. Because if cardiovascular is messed up, then we don't get good kidney perfusion. So those two things just mesh together. We'll see that a little more here. So as we go through this with chronic and acute, we're going to look at acid-base balance again, fluid electrolytes, immunity, and perfusion. Okay? So, and that just gives you some problems that occur. And because it's related to that, this is what the kidneys do. They filter those toxins to keep all those waste products out and keep us from causing anemia. They regulate erythropoietin so that we have good oxygen carrying capacity. They keep up with acid-base balance in the fluid and electrolyte. So when the kidneys or the glomerulus are destroyed, we don't do that as well. And that's why those things get messed up. So, acute renal failure. What's the difference between it and chronic? What?
One is sudden and one is
Yeah, chronic is that develops over a long period of time. Acute means that something has assaulted your kidney. Something has upset the normal flow of what goes on with that kidney. Okay? And when that happens, we talked about one thing, the hydroureter that can cause that. It happens over a period of hours. Sometimes a couple of days, but a lot of times it's within a 24-hour period once that assault happens. If you have a wreck on the interstate, a lot of times you'll hemorrhage, break a leg, hemorrhage. That diminishes volume, That diminishes perfusion, and those patients can be in renal failure by the time they get to the hospital. That's why they put those big old IVs and get fluids going on patients out in the field immediately. We're trying to prevent acute renal injury. So it's rapid decline. We start seeing an increase in those waste products. Your creatinine will go up. If it was a volume problem, your BUN is going to go up too because you're dehydrated. Your potassium, sodium, phosphorus, all those things are going up. Your waste products, you're going to end up with uremia. You will end up in renal failure. Not nice. And as a nurse, you need to understand who's at risk for this and what do I need to monitor in order to keep it from happening. Because we can help with doing that. We can notice that this patient IV got pulled yesterday, but she hadn't had any intake since then. She's not taking her PO fluids. She didn't take any PO fluids during the night or this morning with her breakfast, and now her BUN is elevated. And her output, still good, but it's gone down from 150 an hour to 40. I'm still good, but that trend's going the wrong way, right? So as a nurse, you go in there and do the rest of your evaluation for hydration, your mucous membranes, your tachycardia, your blood pressure, see what's going on. And then you might want to and then you're going to start increasing PO fluids for that patient. Let's see if I can get her to drink more because she's dehydrated and it's affecting her. I don't want it to affect her kidneys so bad that we get into renal failure. If that doesn't work, then you may end up calling the physician and saying, hey, I took this IV out yesterday. I cannot get enough fluids in her. Her urine is going down. It's more concentrated. Her BUN is still up. Can we put another IV back in her for a couple of days till we can get her to drink? That's intercollaborative care. That's part of your job, noticing those things and doing something about it, not waiting till the next day when the physician comes in and is like, oh my God, the BUN is 45. This lady needs to be drinking more. Let's put an IV in. Well, you knew that yesterday, so let's get it done early. Mean pressure of at least 65 to get perfused. All our organs need perfusion, oxygenation to function properly. So with pre-renal, something has happened to mess up perfusion. Can anybody think of something that could happen? I just gave you one. They bled out on the interstate. Your volume went down. So they're not perfusing. What else? Think about your heart. Cardiac arrest, MI. Your heart's not pumping as well as it was. I'm not getting good cardiac output, so I'm not going to be perfusing as well as I was. My blood pressure is down. Okay, that's pre-renal. Intrarenal means something has happened inside this nephron to my glomerulus or to my tubule system. What's something we talked about that acutely affected our glomerulus? I used my hint word, acutely. Acute glomerular nephritis. There you go. It's not cute though, because it started messing up this glomerulus. So that is inside intrarenal. Post-renal means that my kidneys were doing fine. I got perfused. My kidney filter, my GFR is good. It was cooking along. I made urine. But then I get in this collecting duct and something outside of the kidneys on the other end is messing it up. What do we talk about that messes that up? stones, strictures. So that's post-renal. Okay, and that's important because it's going to back up pressures. Pressure in the kidneys are going to cause damage. So normally, pre or post constriction, the kidneys will compensate by activating that renin, trying to get releasing antidiuretic and increasing that volume if they sense their perfusion is down. But it decreases our urine, so we're not cleansing. We're holding on to a lot of toxins, and they end up with azotemia. And the toxins they hold on to also damage in the kidneys and help to decrease kidney perfusion. So it's just kind of a vicious little cycle there, and we have to intervene. So pre-renal is a decrease in renal blood flow that has somehow occurred because of maybe they had bypass surgery. They had to go on pump to get them off, and they had a low cardiac output, so they're not getting perfused well. Inadequate perfusion. Just a minute about how the heart and the renal system interact here. Because something happened, I had a massive MI, and my heart now cannot pump as well. So I have decreased cardiac output, right? So that means that I want to activate some things to kind of try to help that, but by the time I get down to my kidneys, my blood flow is just really not doing well, right? Because my cardiac output is bad. Well, that decreases renal perfusion. The kidneys say, whoa, I need more pressure than that. So they activate renin-angiotensin. They activate antidiuretic. That holds a lot of water and sodium back in our system, which may increase, they're doing that to increase their blood pressure, but when all that fluid gets back to your heart, it's going to go, whoa, I told you I'm sick. I can't take care of this. I cannot pump this much fluid. All right? So now we're going to end up with a little congestive heart failure. And it's just a vicious cycle. They mingle. We got to have both of them working good. Okay? So how do we treat this? Well, we treat whatever's caused that decreased cardiac output. We need to get that heart pumping good, getting that perfusion out there in order to make the kidneys feel better. Get them perfused, keep them from getting into renal failure. So, intrarenal is right here. Something starts to injure that, or the glomerulus, like acute glomerular nephritis, or medications. We got medications we give our patients that damage the kidneys. Antibiotics, there's a lot of them that are nephrotoxic. ACE inhibitors, although we use those for blood pressure, we have blocked that kidney's natural ability to increase perfusion to it, so you have to be careful. NSAIDs, they just decrease perfusion to the kidneys. And if you're on them chronically, you'll see that occur. So anytime you as a nurse have a patient who, let's say they're a threat for AKI because of that accident we talked about, or something else going on, well, it's going to increase threefold if we know they're on nephrotoxic antibiotics. Or we've got a patient who has end-stage renal disease, maybe he's in stage 3, so we're not there yet, but they've just had a wreck and had some hemorrhaging. They're at a higher risk. So you as the nurse need to look at their meds. Don't prescribe my patient NSAIDs, and don't put my patient on gentamicin. Look at what kind of meds they're getting and can they affect their kidneys. And then talk to the pharmacist or talk to the physician and work together to decrease anything that could cause any more problems. Remove the toxic agents, correct any pre-renal problems that are there, and support that kidney during all of it. Post is going to be that obstruction, that stone, that hydronephrosis. And the problem is that we're making urine, but it's backing up, it can't go anywhere, and we're increasing pressures. So the treatment for these patients is get rid of whatever's obstructing it. So you see, acute kidney injury is preventable if we know what to look for, if we know who's at higher risk. So who are some other patients at risk for acute kidney injury?
Athletes.
Why? Let me hear your rationale.
I'm thinking like football players, hockey players, they get hit hard all the time or crushed.
Okay, so direct trauma, blunt
Laceration,
trauma.
yeah.
Okay, I'll go with that. And I also think when somebody said that this morning, they work hard, they work those muscles hard, they might get rhabdo, which the cells damage the kidneys and the glomerulus, and it decreases perfusion. Okay, what else?
Patients with decreased level of conscience that can't maintain a fluid status, like a good fluid status.
Okay, so they're getting dehydrated and decreasing perfusion. Okay. All right. What about diabetic patients? Not acute, that's chronic. That's a trick question. That's chronic. Diabetics, patients with chronic glomerulonephritis, they've already got those problems. Acute, the one that happens quickly. Okay? We've had several rhabdo patients in Enterprise because we're right here by Fort Rucker. They go drop those guys out in the woods in the middle of the summer for their little test thing, and I don't know, it feels like half of them end up in the hospital with rhabdo.
So
But-
they have like a lot of like GI upsets, like diarrhea stuff that could lead to metabolic acidosis and then put them in AKI.
Yeah. Patients that are already in the ICU that usually end up with decreased cardiac output. So all your ICU patients, you're going to be really watching. So what do we monitor for?
BUN, creatinine.
BUN, creatinine, GFR if you got it, output, weight, hydration status, level of consciousness, changes in electrolytes. Okay? So it's not that hard. Just think about what's happening. What am I going to look for? What do I hope it to look like? But if it doesn't, what are some complications? And knowing who's at a higher risk will help you with that. What to look for. So, monitoring, keeping patients from getting dehydration, monitoring that fluid status, recognizing the patients at higher risk, watching their daily weights. Lord, there are so many times that I've asked a nurse going off that's given us reports, so have there been any weight changes? Well, they're doing daily weights. Well, okay, but yay, I'm glad y'all are getting them done, because sometimes I can't find the daily weight. But has anybody actually looked at the last 3 days to see if they've gained weight or lost weight? Especially if you got a congestive heart failure patient. You're giving Lasix to them, taking a daily weight. you want that to work and get fluid off. You can, listen to their lungs, but weight tells you how much fluid did I pull off. Remember, a kilogram of weight is 2.2 pounds. That's fluid. That's a kilogram of fluid, a liter. 1 kilogram is 1 liter. Okay? And then urine output. Just because it looks normal, if it's low normal, you got to go see what it's been doing. Are we coming up? Or are we going down? Look at that trend. That should guide what you're going to do with it. Let's see. All right. History. Changes in the appearance of the urine. We kind of went through this. Did they have anything that could cause them to have acute renal failure? Their drug history. Glomerulonephritis or Polycystic Disease, that's what those are. Anticipate AKI after hypotension or shock, and then a history of any obstruction problems. So you've got a patient who had surgery today and went to PACU, and when they bring them back to your floor, you're on a regular floor, you're like, what took so long? Well, we lost more blood than we thought, and we had to transfuse him a couple of units of Paxil. Right off, your brain should go, he was hypovolemic for a little while. Let's be sure his kidneys didn't get affected. So you're going to be tuned in to looking for volume issues, okay? Blood pressure, tachycardia, urine output, all those things. And of course, assessment hourly. If we are worried about kidney AKI, we're going to be looking for fluid overload, evaluating vital signs. This is our patient just came back from surgery. If they've got a catheter, I'm going to be watching that urine output every hour to be sure that my output's good and that my kidneys were not affected by that hypovolemic episode. There's our lab, which we've talked a lot about. And things that we want to avoid, maintain that fluid balance. We don't want them to get hypotensive because that decreases perfusion to the kidneys. Look at their drugs. We got anything nephrotoxic on there? Lab values, I know, drug therapy. We may have to give them something to get kind of talks about it. You can leave